Hello everyone, I'm Dr. Angela Mattke and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. Today we are discussing pediatric emergency transport services. When a child is critically ill or has been in a trauma, we rely on emergency medical services to stabilize and transport the child to a pediatric medical center. Sometimes this involves transporting a child from a smaller medical center to a major medical institution such as Mayo Clinic Children's Center that really specializes in the care of children and teens. The role of pediatric transport teams provide is key to the stabilization and improved outcomes for these children. Joining us for this discussion is Dr. Stephen Gleich. He is a pediatric anesthesiologist and critical care physician. Dr. Gleich is also the medical director of the pediatric transport through Mayo Clinic Medical Transport. He's an assistant professor of anesthesiology and pediatrics at Mayo Clinic. Dr. Gleich, thank you so much for joining us today.
Well, thank you for having me. I'm a big fan of your show, so it's a real honor and pleasure to be here.
Sorry, I said your name wrong.
No, that's okay. That's okay. It happens a lot.
Okay. So as the director of pediatric transport and pediatric transport services at Mayo Clinic Children's Center, what does that really encompass and what does that mean?
Yeah, it's an incredible job. I'm extremely lucky to have been asked to do this job. It's a broad job, and what our main objective is to really bring the expertise of the Mayo Clinic Children's Center pediatric ICU to the patient before they come to the hospital, before they physically arrive in our ICU. And I'm really privileged to work with an incredible group of women and men who make up our pediatric transport team. Specifically, the roles that I play there's a couple of specific duties that we undertake. First and foremost, our goal is to assure that the transport of children to Mayo Clinic Children's Center is safe, is effective, and efficient. And again, our goal is trying to get that ICU level of care to the patient. Our ICU level of care starts when our team arrives at the patient's bedside. In order to do that, I'm responsible for overseeing a couple of different aspects of that. One is certainly training of our crews. Even prior to our team members joining the team, we start doing a number of educational sessions. We take advantage of the Mayo Clinic expertise here, and we invite a number of our specialists to come provide lectures to us and really gain that knowledge. Infer that knowledge to our team members. Secondarily, we do some more small group education things, and really trying to boost the expertise of our team members, certainly as much as possible. The second main aspect of my job is designing and evaluating our treatment protocols. So, for example, when we are called to transport a child with severe asthma, we have a specific treatment protocol that largely mirrors what the patient would receive once they come to the ICU here. So essentially, it's an extension of our ICU, and we're really giving that ICU level of care as soon as our team arrives at the patient's bedside. We have treatment protocols, certainly not just for asthma, but a wide variety of pediatric conditions and illnesses that we might encounter. And then thirdly, I'm responsible for assuring the quality of our pediatric transport. Certainly, we want the best possible care for ill children, critically ill children, when we transport them, and we regularly review all of our cases to make sure that we're providing that Mayo Clinic level of ICU care when we transport those kids. So certainly a broad job, but again, really extremely lucky to be part of the team.
Okay, team. You mentioned that word.
Yeah.
So who's involved in the team in these transport, both pediatric and neonatal transport teams?
Yeah. It's primarily, there are two primary team members for the vast majority of our transports. When we get called to go transport and evaluate a critically ill child, our first member of the primary team is a pediatric ICU nurse. And it's not just a brand new nurse right out of nursing school. This is an extremely experienced pediatric ICU level nurse who then has done additional training in transport medicine and certainly has experience with that as well. The second primary member of our team is a pediatric ICU and a neonatal ICU respiratory therapist. Our respiratory therapy team crosses over between our neonatal team and our pediatric team, the definitions of which we can certainly get into. But those are the two primary team members that will go on the majority of our transports. Depending on the mode of transport, if we're going by air, either helicopter or airplane, then we'll have another resource transport nurse that goes along with us. And if we're going by ground, then we have the assistance of our Gold Cross team as well. So we have paramedic help as well. So certainly a number of eyes looking after a critically ill child. But certainly we get that expertise from the pediatric ICU nurse and the pediatric ICU respiratory therapist.
I think we have a picture of one of the pediatric transport teams here at Mayo Clinic. Why don't you tell us who's in this picture?
Great. Yes. Well, front and center, you can see I'm glad I'm not wearing the same tie today. But front and center, obviously, you see my picture up there. Next to me to the right, Pete Smith. He's our director of respiratory. On the ends in the red, we have two of our nursing supervisors. On the left is Deb Rokamp, and the right, Lori New. In the back, on the right, on the sweater, Scott Feigl, one of our supervisors as well. And then our individual team members are in the flight suits. And it's a combination of our pediatric ICU nurses and respiratory therapists. And they're great crew. And certainly if my child were ill anywhere and needed to come back to the PICU here, no qualms at all. And I hope they would come and transport them.
Absolutely. So what are the difference between a pediatric transport team and a neonatal transport team? Are there certain age cutoffs?
Age cutoff is the big thing. And some difference in expertise as well. The neonatal transport team primarily will take care of brand newborn babies or babies generally that are less than about 2 weeks in age. And certainly their expertise is required for certainly the considerations of a newborn baby. And that includes premature babies as well. Once they're a little bit older than about 2 weeks, then our pediatric transport team kicks in, and we will transport a newborn child who's 14 days and older, all the way up to about 15 years. So a broad range of ages that we transport.
Absolutely. Now you mentioned their years of experience as an important part of kind of determining if they're going to be eligible to be a transport team member. Is there any other special training that the transport team members receive?
The first criteria for that is experience. We require that our transport nurses, our pediatric ICU transport nurses, have worked in the PICU, which stands for Pediatric ICU, for at least 3 years. So they have to have that experience in the ICU, and that's really the core of what our objective here is to really get that ICU level of care that starts as soon as our team gets there. Once that criteria has been met, they do an orientation period where they work with senior experienced members of our transport team. And then during that time, they also do additional education. I think, as we mentioned, the education sessions, the case discussion. But certainly one of my favorite things that we do is utilizing our simulation center. We do this about at least 4 times a year now, where we take our team down to the simulation center, and don't tell our team this, but we make these scenarios pretty difficult for our team, and we design the scenario such that they have a mannequin who's a pediatric patient, similar in size and age to what they might encounter. They're equipped with their standard equipment that they would take to a situation, and we make these scenarios very difficult from a clinical and evaluation standpoint, or from an environmental standpoint as well. We even can use a mock helicopter as well, so we can we have an outline of a helicopter shell the inside of the cabin, and are beginning to use that more and more for certain scenarios where they might encounter during flight, in a situation where they're returning then to the hospital. So certainly we take advantage of a lot of the resources here at Mayo Clinic, and we try to make our team certainly as best as they can be.
Mm-hmm. What's the role of the critical care physician in these transports?
The critical care physician is integral to a lot of these transports, and it really supports our mission of getting the ICU level care to the patient. Not only are the critical care physicians involved in some of the training for our team, but every transport that our team goes on, a critical care physician, a pediatric critical care physician, is directing that transport. So if I'm not working in the ICU that night, one of my outstanding colleagues is, and they are right now answering phone calls from the team, certainly about what the team is seeing, what's going to be the best for the patient, and certainly if any questions or problems come up while the team is initially evaluating the child or en route back to the hospital. So certainly there is a strong involvement of the critical care physician during all transports, and it's very analogous to being in our ICU, where you have a critical care doctor who's then overseeing and treating the patients who are in the ICU. We recently were awarded a grant from the Mayo Clinic Center for Connected Care, and this is have to thank one of my colleagues, Dr. Chris Russi from the emergency department. We worked on this grant together, which is going to allow us to utilize telemedicine in our pediatric ICU transports. And telemedicine is a device that, similar to a laptop that our team will take, included in that device, we have high definition cameras and high definition audio two-way. So not only can I see the team and the patient, but they could see me as well. And it really adds a lot of information then to the critical care physician who's using this. The idea being that when our team arrives at the patient to initially evaluate and stabilize them, they set this device up, and then the physician is intimately involved in assisting that stabilization if need be. Certainly, it's very helpful to see things. Picture is worth 1,000 words.
Absolutely.
And it certainly, I think, is a big step forward versus our current system of using a phone call to describe the situation there. We hope to be implementing this. It's going to be on a trial basis first for the next year or so. We hope to be implementing it soon within the next few months. And my ultimate hope is that we're going to use this on the vast majority of our transports once we work out some of the kinks with it. But I think it's going to be a great step forward in evaluation of critically ill children.
Absolutely. So last week we had Dr. Fang on, and we talked about how we're using telemedicine to help with neonatal resuscitations. But this will be one step further. This will be after the resuscitation, when maybe that disconnection with some of our health system sites occurs, we'll be able to pick that back up.
That's right, yes.
In the transport, and continue to help support that child, stabilize them, and start the ICU care like you're already doing.
That's right. Yeah.
Fantastic.
Yeah, we are working in addition. Right now, I don't think we're going to be able to use this in the helicopter when the helicopter's in flight. However, our ground ambulances should have enough connection that even if there's an issue when they're driving back, we'd be able to connect and see how things are going and help as needed.
Okay. Do the critical care physicians ever actually go out on transports? Are they ever part of that team that's flying? Or?
Occasionally. We train our primary teams, that pediatric ICU nurse and the pediatric ICU respiratory therapist, so that generally we don't have to go. I have absolute complete confidence in all of our transports that they accomplish. They're extremely experienced, well-trained, and ready to go. Occasionally when we have unique situations, and one of the unique situations that we more commonly will involve a physician actually go on the transport would be for a child who needs ECMO. ECMO is extracorporeal membrane oxygenation, and it's really one of our highest level of therapies. Generally, we use ECMO when our conventional treatments have failed, and we need a really advanced technology to support a child until he or she can recover. The most common reasons for that would be if they have a severe pneumonia, for example, we're going into respiratory season, bronchiolitis. If it gets to that point where our usual treatments, for example, a ventilator don't work, then the next step is to use this more advanced therapy. Because of the associated characteristics of the ECMO machine and the logistics of it, we typically will involve a physician for those transports. Other situations where we might involve a physician are relatively few and far between. ECMO is certainly the most common reason why we would do that.
So, what are the most common things that children are being transported for? You mentioned pneumonia, you mentioned asthma. What other things?
It's nationwide. We actually, including our area in the upper Midwest and throughout the United States, the most common reasons that children need transport for illnesses are number one, respiratory problems, so breathing problems. And as we mentioned, we're getting into the winter time now. We're getting into bronchiolitis, which is an infection in the lungs, usually caused by viruses that causes a lot of breathing difficulties. And anybody in a children's center knows that once winter comes, we see a lot of increase in admissions for breathing problems. A lot of these children need to come here. We offer certainly advanced levels of help with breathing that may not be in place at other centers, and so we transport them here. And that's probably, I think that's number one reason why children will come here, or why we transport children. The second reason is for neurologic problems. So problems with the brain, the spinal cord, along those lines. And the most common subset in that group would be children with seizures or who have had known problems with the brain, such as brain tumors, things like that we would transport here as well. So respiratory, neurologic, including the brain, and then thirdly, trauma. So injuries would be the three most common reasons they come here.
Okay. What area are we transporting children to Mayo Clinic Children's Center for? And I think we actually have a picture to help us demonstrate this.
We primarily, most of our transports will occur in the upper part of the Midwest, where our Mayo Clinic Rochester is located in southeastern Minnesota, as the map shows, designated by the green triangle, upside down triangle there. We have, that's our main base for our pediatric ICU team, and we typically will dispatch them from the Rochester campus. We also have helicopter bases in Mankato, which is to the left of your screen in the upside down green triangle, and then in Eau Claire, Wisconsin as well. The circles around those bases imply the range of the helicopter. Okay. So generally 150-mile radius around the base is typically where we will transport from. We also have a number of other modes of transportation, and really all over the upper Midwest, including the Dakotas, is where the majority of our patients will come from. We also can go nationwide and internationally as well if needed. Those certainly are less frequent type of transports, but anywhere our team is needed, we'll go.
Okay, let's talk about the different types of transports. So helicopter, ambulance. How do you get in the national transports?
Yeah. No, it's a good question. The majority of our transports are with our own equipment. So Mayo Clinic Medical Transport owns and operates an awesome fleet of vehicles. We have 3 helicopters here, designated as Mayo 1, even though there are 3 of them. We have 3 Mayo 1s.
We hear them fly over our house a lot.
Yeah, that's right.
I always say, there goes Mayo 1.
There goes Mayo 1, yes. We have one King Air turboprop fixed wing airplane, and that's we utilize that for certainly longer distances outside of that 150-mile range of the helicopter. And then certainly we have a large fleet of ground ambulances as well that we utilize. Those are our primary modes of transport. If we need to go further than that, we have opportunities to work with other transport companies to we utilize their longer range, usually fixed wing aircraft, business jets, to to go and pick up patients wherever they may need to come here from.
Okay. We have a great video of Mayo 1 here. Can you tell us a little bit what we're seeing?
So this is the helipad on top of St. Mary's Hospital, and this is Mayo 1, one of our helicopters. It's a Airbus EC-145 helicopter. It's a twin-engine turbine medical helicopter, and it's very popular amongst medical transport programs around the country. We see that aircraft landing on the roof of the helicopter, or excuse me, the roof of the hospital, and two of our transport members are in this video. They're transporting an adult from the helicopter directly into the hospital. We are certainly very fortunate to have that direct connection between the helipad and the hospital, such that a critically ill child immediately gets off the helicopter, comes into the hospital. They come directly to the ICU or the emergency department, wherever their destination is, and we continue that level of care that they've been receiving.
So in that video, we saw one of the helicopters or pilots landing the helicopter there. So the pilots are obviously a very integral part of the team. Do they receive any specialized medical training to be part of this team?
The pilots themselves don't necessarily receive medical training, but the pilots are absolutely outstanding. They far exceed the FAA minimums that are needed for this type of job, and they have extensive experience flying around the southeastern Minnesota, western Wisconsin areas. In addition, one of the benefits of our program here is that we have specialized equipment that allows us to fly in lower visibility conditions than some other programs. Okay. When there's fog and clouds and rain and so forth, our program and our pilots and our team have developed ways that we can approach even an outside hospital. We can safely approach there and in lower visibility and lower cloud conditions than otherwise would be safe. We test that technology pretty regularly, and it allows us to really help with a very fast, efficient means of transportation when otherwise it may not be possible due to weather conditions. So without question, the pilots, the aviation team, the maintenance team, the paramedics that drive the ambulances and assist with patient care, absolutely integral to the team, and certainly grateful for all of their expertise and help.
Yeah. I would echo that. I agree with him as well. The ambulance glow costumes who's coming to my clinic as an outpatient pediatrician and are helping us with children who are, seriously ill, need to be brought to the emergency department and seek a higher level of care. So I'm grateful for all they do and the communication that they ensure with us as well, which is fantastic. So
that's great. That's great.
Let's talk a little bit about how you are able to provide that ICU level care on these transports. What kind of interventions are you able to do?
We're able to do almost everything that we can do in the ICU. We can do in the transport environment as well, and that means starting that ICU level of care, and not just regular ICU. It's really specific pediatric ICU level of care as soon as our team arrives. We carry with us a lot of the same equipment, a lot of the same medications, and a lot of the same therapies that exist in our ICU as well. Specifically, we have a whole wide range of medications. Certainly, everything from breathing medications to IV medications that we can start to support a child, to start treatment of a child as soon as we arrive. We have a wide variety of breathing devices, including mechanical ventilators, so breathing machines that can help with respiratory problems. We have, and then ultimately, if need be, we have a plan in place to transport a child on ECMO as well, which is certainly one of our highest level therapies.
And would that be done in the helicopter or in the fixed wing?
Generally, because the ECMO machine, and anybody who's seen an ECMO machine realizes there's a lot of hoses and tubing and a lot of IVs that generally go with it. Typically, we need a slightly larger environment to appropriately manage a child on that type of therapy. And so generally what we'll do is if we need to rapidly deploy our ECMO resources to help stabilize a child, we'll utilize our helicopter to get the equipment there, to get the personnel there. Once we are in a little bit better spot, we're a bit more stable. Because that all that equipment takes up a bit more room, we'll return in a ground ambulance. So, so we're tremendously lucky to have all these resources here at Mayo Clinic Medical Transport, and we really try to deploy those resources and use as many as needed for each specific patient, and really take in individual patient symptoms and considerations.
I want to go back to something you said in the beginning about using treatment protocols. How do these help improve the care of the children that you're transporting and using interventions for?
Yeah, the treatment protocols that we develop are based on medical studies, are based on things we know work for certain conditions. So we talked about asthma. We can talk a minute about seizures, because that's another common type of patient that we might transport with seizures. We utilize our awesome pediatric neurology team here at the Mayo Clinic Children's Center to develop a protocol for the initial treatment of seizures, and then more extended treatment if the seizures are difficult to control. We initially developed that protocol here for the inpatient setting, meaning a patient who's in the hospital. Now we've applied that to our transport team. So really, as soon as our team arrives, we're going to start that protocol. Sometimes by the time they come to the ICU, we're already on step 4 or 5, and we've gained that much time by sending that ICU level team to pick up the child and start those treatments sooner, so we can hopefully get control of the seizures faster and ultimately improve how the child does.
Fantastic. We're getting close to the end of our time now. And so I want to bring it back to the parents and the families that are going through this process of having a child who's critically ill and needs transport to a higher level of care. How can parents be involved in this process, and how can we support them through this process so they know what's going on with their child?
Yeah, it's certainly I have 2 children at home, and it's fortunately I've never had to see them transported by a medical team, but I can imagine it's an extremely stressful time. We rely on parents, and they're integral to the process. First and foremost, certainly to all the parents that are watching out there, your child is in absolutely great hands. I would have no qualms about sending my child with our transport team to come here. There are a couple of different types of transports we do. So when we utilize, and they're based on the mode of transport. So when we utilize our ground ambulance, typically in that situation, we'll have enough room in the ambulance to allow and invite the parent to come along with us. And we found that's very helpful. Certainly, it's a very anxiety-provoking situation, particularly for the child. In our fixed-wing airplane, so our turboprop airplane that goes, again, usually longer distances, usually we have a room as well. Not always, but usually we have room as well for the parent. Where we sometimes usually don't have room for the parent is in our helicopter. Because of the way the helicopter is designed, and because of the weight and balance requirements from the FAA, most of the time we don't have room for the parents, and it's certainly a very stressful time when we have to separate. What I would say is I'm more worried about the parent getting to the hospital safely versus the child, because I certainly have full faith in our team, not only to get the child there safely, but while initiating treatment as well. So it's a stressful time without question, and we keep the parents, even when we have to separate, we keep them informed throughout the process.
Okay, fantastic. Dr. Gleich, thank you so much for all of your information that you've shared with us, and I hope it's been enjoyable for you as well.
Oh, thank you. This is a great show, and really happy to talk about our program and our team, because very proud of what we do, and certainly the people that do it are outstanding.
Absolutely. Thank you, everyone who watched. You can catch the next Ask the Mayo Mom on December 20th at 11 a.m. Central Standard Time. Dr. Ozma Chetta, who's a pediatric gynecologist, will be joining us to discuss abnormal menstrual cycles in young women and teens, and specifically how they, relate to polycystic ovarian syndrome. Thank you, everyone who watched, and have a wonderful day.